Good morning, everyone, and welcome. Thank you for attending today's webinar. We're excited to present to you our fourth webinar, Does Canada Provide Culturally Sensitive Dementia Care? As part of our webinar series of bringing communities together around brain health and aging, hosted by the Social Planning Council of Ottawa. My name is Sybil Briganza, and I'm the coordinator of the Ethnocultural Seniors Program at the Social Planning Council of Ottawa. I will be your facilitator and host for today. Before we begin, I would like to thank our funders, Centre for Aging and Brain Health Innovation, Ontario Trillium Foundation, and the New Horizon for Seniors program. Today's webinar, Does Canada Provide Culturally Sensitive Dementia Care?, explores the current state of dementia care and what a culturally responsive model of care would look like at the policy level. The session will uncover a number of realities, including the increase of seniors, immigration, and dementia in Canada. It will consider innovative and intersectional approaches to aging alongside policy, essential to support inclusive planning and affecting ethnocultural seniors and other distinct needs. The agenda will start off with a presentation from Ngozi and Iroanyah. We will have a break for question and answer throughout the presentation. Just a few housekeeping rules. Please mute yourself if you haven't already. If you have any questions for Ngozi, please put it in the question and answer box, and we will take your questions as we go along. All of the webinar series will be recorded and uploaded at our website, Ottawa Community Partnership for Health Equity, and associated resources will also be put there. Some of you had questions last time for Ngozi, and that will be answered on our webinar as we go along for the next week. So going forward, we have 3 more webinars that are coming up, held every Tuesday from 10 to 11:30. You can register for this on our website, or you can connect with me if you need more information. Thank you once again for attending, and we're excited to have Ngozi back with us today. So I'm just going to give you a brief introduction of Ngozi. She's very, very modest, and I was insisting that she give me a longer introduction, but she insisted, no, this is it. So I'm just going to introduce to you our very special speaker for today. So Ngozi is a third-year PhD student in the Department of Health Policy and Equity Studies at York University. Her research centers on the experience of racialized immigrant seniors with dementia, health, policy, and services. Ngozi has a bachelor and a master's degree in political science, where she discovered how political determinants of health also contribute to health inequities and poor health status. Her interests include social justice, community development, health systems change, and health equity for marginalized groups, seniors care, global health, and maternal health. So please join me again in welcoming Ngozi. And I'll turn it off to you, Ngozi. Thank you.
Thank you, Sybil. If people have a hard time hearing me, please let me know. I'm on some headphones that may be malfunctioning, and there's a lot of construction going on my street. But thank you for having me again. I'm honored and thrilled to be here again. For those of you who are joining us for a second time, welcome back, and thank you for joining us. I really appreciate it. For those who are joining us for the first time, welcome, and thank you for coming and taking time out of your day to sit and listen to us. So yeah, I'm going to be talking about dementia care and approaches to dementia care in a culturally sensitive or culturally appropriate way. But I'm going to just add a disclaimer. Can I have the first slide, Malin? Is that okay? Perfect, thank you. So the title of my talk is actually Dementia Care in Ontario, a Culturally Sensitive Approach. I know on the flyer and what Sybil introduced was talking about dementia care in Canada at whole, and that's my mistake. Last week's talk was about research on immigrant ethnoculturally diverse seniors in Canada and experiences with dementia and dementia care services in Canada. And the research looked at sort of what the landscape was that. This week, I'm actually looking at more focused at Ontario's approach to dementia care and sort of how that attends to the realities and experiences of immigrant seniors. So I wanted to make that disclaimer and apologize. In answer though to the question, is there culturally sensitive dementia care in Canada? The short answer to that is yes. The caveat to that answer though is that while there are culturally appropriate and culturally sensitive approaches to dementia care, you'll more find it at the ground level. And by that, I mean within the community, specific communities themselves, they have taken up to provide dementia care services from within a cultural lens that's aligned with the community that they serve, not exclusively, but predominantly so. You will also have at the municipal level, maybe some municipalities have partnered with other communities to develop dementia care programs or seniors health programs that are more specific to those communities. Again, not exclusively. You may have that. But at the top level, at the federal, provincial level, when we talk about policies and initiatives that specifically address culturally appropriate and attend to the cultural needs of immigrant seniors in reference to dementia care, I have not seen that. And actually this presentation is going to speak to that much more succinctly. So we'll get started. So the picture you see here is myself and my papa. He's smiling and we're holding hands and sharing a joke. Even with his dementia, my dad and I can still find little points of joy and glee and laugh to ourselves about things. So I'll just begin. Next slide, please. And so the objectives for this presentation today, we're just going to go over some things from last week, just sort of paint the picture and give the context again of sort of why this research is needed and sort of what I was looking at within the dementia care strategy. We're going to talk about intersectionality as a primer. It's a sort of a bigger field, a bigger topic that we can't cover all in this presentation, but I'll introduce a primer to it. We're going to talk about intersectionality and health equity, intersectionality and health policy, and then the Ontario Dementia Strategy as it relates to all of this. I am gonna try to put up some opportunities for key terms, but I don't know if we're gonna have the time, but we will have a question and answer period. I like to keep things informal. So throughout, because it's a long presentation again, I'm gonna break and for any questions or comments or just people to stretch, get some water, do whatever they need to do. And we'll continue on from there. But I like to have a dialogue. I like to have a conversation back and forth. I don't like talking at people, but talking with people. So hopefully we can have a great experience all the way through. Can I have the next slide, please? Thank you. So from last week, so this slide talks about sort of the background and the picture that I wanted to paint. I wanted to give context and the background for why we're doing this. So if we remember from last week, and for those of us who weren't here last week, 2016, the Canadian census revealed a significant shift in our demographic for Canada. The way Canada looks, the way Canada sounds, the way Canada feels, it's changed significantly. So in 2016, it was noted for the first time in history, those who are 65 and older were actually outpacing those who were 0 to 14. By 5.9 million 65 and older and 5.8 million. Within the 65 and older group as well, 85-year-olds and older were also growing at a really fast rate in terms of numbers. And so this holds great significance when we think about our population changes and our aging population and what sort of services, policies, and provisions we need to be proactively in thinking about. Now, obviously, people who are 15 to 64, that's the biggest cohort, and they're at about 23.9 million, I want to say. But even those numbers are decreasing over time. And so we're thinking about an aging population that's not necessarily having younger populations to fill that back up. So thinking about how our governments are going to respond to that, how our programs are going to respond to that. The great thing is people are living a lot longer, which is wonderful, and people are living in better health as well with medical technology. But the reality is there are some age-related health issues that we need to sort of be attended to as they come up. And so the sort of image on the right looks at Ontario. Ontario being the most populous province in the country today by 2016 standards. Similar trends we see as the whole of Canada. So in that 65, those who are 65 and older are actually 2.3 million, and those who are 0 to 14 are 2.2 million. Now projections say that by 2046, Those 65 and older are going to be 4.6 million, and those 0 to 14 are 2.9 million. And these are all approximations and projections, but there's accuracy in that. And so again, we're looking at almost twice the number of those who are 65 and older as compared to those 0 to 14. Next slide, please. Thank you. And so another trend that we saw in 2016 from the census was that the immigration trends had changed dramatically. So 2016 actually saw the biggest rate of increase for immigration since 1921, so almost 100 years difference, which is amazing because more people are coming to Canada. So it was noted about 1 in 5, so about 20%, to be accurate, 21.9% of people identified as being foreign born. So that's a huge increase. In that though, in those who are identified as being foreign born, we also saw increased diversity in the source continents for newcomers. So traditionally we had people who would be coming from Europe, European countries, and that's changed gradually, and now more starkly that has become countries from Asia and from Africa are now becoming the source places of origin for people coming to Canada. In that as well, another trend that we saw was an increase in the amount of seniors who were immigrating to Canada. So when we think about newcomers to Canada and immigrants, we typically think about those in working years. So those, in their 20s and 30s and their 40s who come to Canada. But now we're seeing people who are coming in their 60s and 70s. Some of that has also been from the family reunification immigration policies, people coming to join their families after their mate retired back home, or maybe just to be with their families now. So we're seeing people who are coming to Canada who have lived most of their lives in a different cultural context, and now coming to Canada and continuing their lives here, which also, presents some implications for how we think about policy and services moving forward. Next slide, please. So the numbers in dementia. And so when we think about dementia in Canada, we know that it's increasing, the numbers of dementia in Canada. So, but right now there's currently about 564,000 people who are experiencing dementia, who have been diagnosed with dementia. Those estimates by 2032 would be about just 962,000. There's almost about 1 million people. Again, these are approximations. 2032 is not a far time off. It's only about really 11 years, which is terrifying when we think about how quickly time is going, but it's not that far off when we think about how many people may be diagnosed with dementia. So estimates point now about 25,000 people a year are diagnosed. 65% of those diagnosed are women, and 1.1 million people are affected by dementia in Canada. And so that last number, 1.1 million, when we think about being affected, we're talking about caregivers, we're talking about family members, neighbors, etc. And so it's not just the person who is experiencing dementia, but also those around him who provide support are also being affected by dementia. Currently in Ontario, I have here 175,000, but I've seen 175,000 to 220,000. And I've also seen that by 2030, we're looking at perhaps 430,000 people being diagnosed with dementia in Ontario. So again, these numbers are approximations, just given the fact that some people don't get diagnosed or wait longer to get diagnosed, but pretty significant in terms of what we're looking at. Also, some also numbers just to consider, though dementia, I don't want to say typically is seen, but though dementia is seen in those 65 years and older, dementia is not exclusively for that age group. People have been diagnosed with dementia as young as 45 years of age. And so it's something that people associate with advanced age or older or aging, but it's not exclusive to that. I just want that to bear in mind. And also that dementia is not a normal part of aging. It's not something that is a given to happen to someone as they age. I wanted to put that disclaimer out. Next slide, please. So what does all this mean? All these numbers, all these, excuse me, all these numbers, all these facts, all this information, what's the punchline? So basically what it means is that we have a very unique situation where we have an aging population that's very racially, ethnoculturally diverse, and that's coming from immigrant backgrounds. So all this in total means that the services and the policies have to sort of be attuned to their unique needs. And it's incumbent upon provincial governments, federal governments, municipal governments, it's incumbent upon them to be proactive and to be able to establish and design and set up these policies and programs so that we're not being reactive years later where people may fall through gaps. So that's sort of the impetus from my, my research that I talked about last week. Next slide, please. Thank you. So my research was actually premised on my dad's experience. For those that weren't here last week, my father was diagnosed with dementia in 2008, last year, by his family doctor. And I had been working in the healthcare system, and even with me working in the healthcare system at that time, it was still a lot to navigate and try to understand and try to figure out the best way to support him and provide him with the right programs. And so I began thinking, what does that look like for other immigrant seniors and their family members in Canada? What experiences are they having? So that prompted me to do my scoping review. With the research question being, what is known about the experiences of ethno-culturally diverse immigrant seniors and dementia care services in Canada? So in my scoping review, I selected 65 articles. After having gone through them extensively, I took 14 from them to see what the experiences were. Overarchingly, it was that people who were from immigrant backgrounds, racial, culturally, ethnically diverse backgrounds, who were experiencing dementia did not have an easy time. There are a lot of barriers to accessing dementia care services. From that, there were three main themes that I saw: culture and language, trusting relationships, and sort of new and different theoretical approaches to concepts of dementia. So when we talk about culture and language, how that is a barrier, you know, off the top, you know, people who come to Canada may not have a command of the English language, you know, to effectively navigate healthcare systems if they have a health background. Oh, someone's asking me, is there background noise? There might be. I have my fan on. I can turn it off and see if that makes a difference. Give me 1 second. So I've turned off my fan, so maybe that might be helpful when people hear me. So culture and language as barriers to those who are trying to access dementia care services. So language being that you might not be able to understand or have command of the English language, but also language when we think about how dementia is in different cultures. Some cultures don't have an actual word for dementia. Some cultures may describe the symptoms and the characteristics of dementia very differently and may be housed in different cultural traditions or cultural perspectives, which in fact may be a barrier. Culture itself, thinking about what dementia is for some cultures. Dementia may not be seen as a medical issue. It might be seen as just a regular part of aging, but it might also not be seen as a medical condition that needs medical attention. And that can delay health seeking and support for those who are experiencing it. Also, when we talk about culture, when we talk about dementia care, some cultures are not really attuned to having home care because in their culture, the family is to take care of loved ones as they age or loved ones as they get sick. And that being sort of an imperative feature of that culture may dissuade those from accessing home care services, which could help in managing dementia symptoms for those. Trusting relationships was another theme that I discovered in my work, in my scoping review. Trusting relationships between healthcare providers and recipients, consumers, clients, with those experiencing dementia. And so if you walk into a healthcare institution, a clinic or a hospital, or you see a doctor or whoever, and you don't feel that you are being seen, or you don't feel that you are being taken seriously, or you feel that your needs are being dismissed, that is going to erode trust, and that is going to make you not want to go back. It's not going to make you want to listen to what they have to say if they're not attending to your specific needs, given that be they cultural or language-based or what have you. As well, from the provider side, some providers may not feel competent or confident enough to be able to provide dementia services from a cultural paradigm. And because of that, that as well may sort of interrupt or taint the relationship. New theoretical approaches to concepts of dementia. So in the research, I saw a lot of researchers talking about sort of looking at people in a holistic totality framework. So looking at dementia, not looking at dementia as just the disorder itself, but looking at dementia amongst the whole person and their lived experience and other identities that they house within them. So it's not just this person who has dementia, but it's this person who's, you know, coming from this background of this age, this gender, with this cultural context, all of that in tandem should be considered when accessing dementia care. And they found that that was a more fruitful approach to helping people feel more comfortable and competent with accessing dementia care. And so some recommendations that I had, first off, is more research within these groups and populations, so within racially, culturally diverse immigrant seniors. And so making sure that we hear their experiences and that we know what they're experiencing and what their actual needs are, so the policies and programs and services can attune to that. As well, having more diversity in this research. So the articles that I found leaned heavily more towards South Asian populations and East Asian populations, which is wonderful and needed and absolutely important. But there are other community groups as well that are underrepresented, whose voices also need to be heard and experiences need to be heard. Other recommendations: increase in cultural awareness, increased trust between providers and groups, increased staffing, solutions, and training. And so I touched on this last week, but I really wanted to really emphasize that when you work in diverse communities, it's always imperative. I don't even want to say good. It's imperative to have a staff that represent the communities that you serve. The example I used last week is that there is an organization that serves predominantly women. You're going to want to have women on your staff. Just makes sense. So if there's an organization that serves a mixed group, a racially diverse group, it's incumbent that you have people that represent your client base. For people to feel more safe, people to feel more seen and heard and respected, but not just at a tokenistic level. So these people should hopefully be included in decision-making and operationalization programs within the organization as well. I also talked about coordination between service providers as a recommendation. So, and you'll see the total mandate for immigration, settlement services, community-based organizations, dementia care services, they all have the same mandate: to support someone, to support people who are coming to the country, people who are, who might have dementia issues. But they operate in silos. So oftentimes immigrants, settlement services are not familiar with dementia care services and vice versa. And because of that, people may fall through the gaps, because if someone's coming to the country, they may go to the immigrant settlement services because they don't know or feel comfortable at other institutions related to dementia. And the immigrant settlement services may not know of what services could support them along that journey. So having increased coordination and partnerships will be helpful to be able to support everyone from those angles. Next slide, please. Thank you. So here we talk a little bit more about health and equity. And I'm gonna stop here for a second. I'm just gonna ask if anybody has any questions or concerns. So that was about maybe 15 minutes of conversation. And it's a recap for those who were here last week and new information for those who weren't. So are there any questions and concerns that anybody wants to bring up?
Hi, Ngozi. No, there is no questions at this point.
Perfect.
I just wanted to let you know that there is still a clicking sound, and it could be your earring or something hitting the mic.
Oh, okay. I will. Should I take off the earrings? I do like them, but I will take them off. Hopefully this is better. I'm going to unplug and plug in my mic again.
Okay, yeah, so no questions at this point. I will continue.
Hand raised for hand raised. I saw it, now it's gone.
Oh, you had a hand raised, okay.
Someone had a hand raised. I don't know where it is now. But if not, I'll continue on.
Yeah, okay.
Okay, perfect. So from last week, we talked about equality versus equity. And so if we look on the picture here, on the left-hand side, we look at a representation of equality, which is sameness, everybody being treated the same, one size fits all model for people to achieve whatever ends they need to achieve. And if we see in the image on the left-hand side, it doesn't actually help everyone, though it is an equal way of distributing resources. It's not an equitable way of distributing resources. The image on the right is an example of equity. So an equity is describing fairness in the distribution of resources and services that attend to the needs of individual groups and people for them to achieve, in this case, better health status. So the person wearing the blue shorts, the blue pants, and the red shirt does not need a box, in fact. and the person wearing the green skirt and the pink shirt actually needs 2 boxes. And the person in the wheelchair needs a ramp and a little bit of an incline to be able to see and see the game. So that's when we think of, that's what, you know, a representation of what equality versus equity is. These are words that are sort of being very popularized in modern discourse, but it's nice to know, it's good to know the differentiation between them. Next slide, please. Thank you. As it relates to health equity, it's the absence of disparities. It's the absence of disparities in health and its key social determinants, which I will touch on later, that are systematically associated with social disadvantage and disadvantage as a whole. So that's sort of a working definition of health equity, but I'll get more into it in a minute. Next slide, please. Intersectionality. So intersectionality is sort of the basis of my research that I do. And it's sort of, I love this concept because it really attends for me to what I think the lived experiences of immigrants, ethnically diverse and racially diverse seniors as it pertains to health and as it pertains to dementia care. And we're going to go through what intersectionality is and how we can apply it to health policy when we think about how we can have policy that's more equitable for groups. And so if you look at this image here, you have race, gender, and class, and they're all different lines, and they're all different identities as they were, but they all meet in the middle. And in that middle is the intersection. And that intersection is the personhood that each person exhibits. And so someone who is racialized, of a certain gender and of a certain class, all comes together and forms that person. And that's sort of a very loose, top level understanding of intersectionality, but I'll expand on that as I go forward. Next slide, please. So the term intersectionality was actually coined by Kimberly Crenshaw, this woman here, back in the 1990s. She's a critical race scholar, a critical race legal scholar out of the United States. And she was looking at the experiences of Black women in the judicial system, in the legal system, and sort of what they were experiencing. And what she found was that Black women were treated differently than white women and treated differently than Black men. Though they occupy they have a footing hold in both of those categories. They're women and they're Black, but they're not white women and they're not Black men. And they were treated differently in the judicial system. They occupied their own unique space and how they were treated. And so from there, she coined the term intersectionality as the intersection of race and gender, and in her case, class as well, came together to form a person. And this formed person interacted with the judicial system in such a way that it manifested in the outcomes. It manifested in sentencing and manifested in rehabilitation options. So it was the intersection of all of those identities to form one person, and that whole person was then formed a relationship with the judicial system. So Black feminist thought, it's a discipline, it's an academic discipline from which intersectionality sort of arose from. Black feminist thought arose in the 1960s and 70s, and it really looked at the experiences of Black women in academia and society, politically, and sort of how to attend to the way they were treated in systems of oppression they were experiencing. But the phenomenon of intersectionality experienced by women of color and people of color did not come about in the 1990s. It's been around for a very long time, looking at the way people who occupy various locations and how that occupation of various locations simultaneously dictates the relationships they have with systems of the state. And well, that's very big, but I'll break that down a little bit more. A quote here by Audre Lorde. She was a political activist and feminist and scholar. She had said that there is no such thing as a single issue struggle because we do not live single issue lives. So to that, we cannot divorce ourselves from the multiple identities that we have. We are all of them in one. We are not just one type. And so that's sort of the lead way into intersectionality. Next slide, please. Thank you. So as you see on the left-hand side, this depiction of intersectionality, you see race, sexual orientation, gender identity, nationality, and ability. So all of these sort of coalesce into one, and they make up one person. And I use these different depictions because I want people to really understand the concept of intersectionality. It can be a very heady, abstract, out here concept, so I use different representations because it might appeal to someone in a different way. So intersectionality as a definition, there's not really one definition. There's many definitions of it, and there's many uses of intersectionality. It can be used as a methodology, a tool, a framework, a theory, and a paradigm. And the beauty of that, the multiplicity of its uses, is that it can be used in various disciplines, and it can be very much used as an agent of change. So intersectionality, it's a theoretical framing of sort of difference and of experiences, but it also can be used as a way to enact social change. Because intersectionality looks at power structures. It looks at how people are formulated by systems of power in society, and how these systems of power dictate your life, basically, and how your life is going to turn out. And intersectionality likes to challenge that, wants to challenge that, and aims to challenge that. So it can be seen as an agent of change. This quote here by Collins and Bilage is another intersectional scholar. I won't read it out just in the interest of time, but it speaks to what we've been talking about, how intersectionality is about the various social locations and how they work together to define a person or characterize a person and how it interacts with systems of power. Next slide, please. So intersectionality, it's non-defined in terms of there's not one definition, but there are central features that are apparent in all of its uses. One of the features is that human beings are not reduced to a singular characteristic. So I am not just a woman, period. I am not just Black, period. I am not just from a certain socioeconomic class, period. I am all of them in one. The human experiences cannot be seen as prioritizing one factor over another. So it's not the matter of I'm a woman, and that's the most important thing, or I'm a Black person, so that's the most important thing. With intersectionality, they're all sort of weighted equally, and they're all treated equally in terms of policy. That these social categories are fluid. So things like race, gender, class, sexuality, all of those are fluid constructs or social fluid constructs, but they're not fixed. So intersectionality really really uses that to say that, you know, these categories that we give to people, they're dynamic and they're changing. And so that's going to have an impact on the way we think about our policies. So when we think about policies for women versus gender versus family, we think about policies for seniors, you know, back in the 1970s and 1980s, the construction and conceptualization of what makes us seniors now has changed over the years. And that's going to be seen hopefully in the policies that come as a result. Before, you know, seniors, and for example, for ability, before people who were differently abled were seen and classified maybe in a way that would not necessarily provide for opportunities and true equality and equity in society. The construct of ability and differently abled has changed over years, and so the policies have reflected a more inclusive form of when we talk about differently abled people. So that's just some examples. Another feature is that social locations are shaped by processes of power and social structures. And we're going to talk about what that actually means in real time. And when we talk about how these policies and structures shape me, how they define and tell me who I am, and thus how I'm going to interact with them and what kind of relationship I'm going to have with them. Another central feature is self-reflection. So people, when they do intersectional research, taking stock of their positionality. So who are you? What sources of privilege do you have? What sources of oppression do you have? And how that attends to your work and to your research, which is also very important. Next slide, please. Thank you. And so in the interest of time, I'll just sort of pick out the more salient points. Intersectionality attends to themes of social justice and systems of power and oppression, both overt and covert. Sometimes these systems of power are multiple, they're complex, and they're overlapping. But when we talk about health inequities, we need to talk about the multiple and complex identities that make up a person. We can't talk about, I know for the most part, when we think about treating someone who has a disorder or a dis-ease, we look at that particular dis-ease or that disorder, and we want to remove it from the person and treat the disease and the disorder. But in doing so, we remove a lot from the experience, and we remove a lot from the realities of someone who are experiencing dementia in this case. So it's incumbent upon us that we take into account their social identities, their immigration status, and other factors that contribute to their personhood when we talk about dementia. If not, people will continue to fall through gaps. Next slide, please. Thank you. So when we talk about intersectionality in health policy, so health policy has tried to be equitable. We tried to incorporate a sense of equity and fairness in health policy over the years, and several ways that has been done is through several approaches. Social determinants of health, some of you may be familiar with that. There's also the sex and gender-based analysis plus, and a health equity impact assessment or health impact assessment approach. All these approaches sort of look at social determinants of health. Let's start there. Social determinants of health are the non-medical factors and conditions that influence a person's health status. So things like your education, things like your environment, your physical environment where you live, things like your job, employment, things like your social networks, things like culture, gender, language, all of those things impact how you're going to experience health in this country. So for example, if you have a good job, if you have a good job that has good benefits, that's steady and stable and secure and pays you enough money or a lot of money, you're able to afford vacations to decrease stress. You're able to afford nutritious, proper foods. You're able to afford to live in a good neighborhood even where you can feel safe and go home. And all of those things are going to have an impact on your health status. Sex and gender-based analysis. So this came about in 2009 from the federal government. They wanted to have a gendered lens to their policies to ensure that women and men, what the differential effects or impacts would be of their policies. And they wanted to make sure that largely women were treated fairly in distribution and implementations of their policies. But the sex and gender-based analysis really privileges gender as a construct in terms of how people have equitable access to healthcare or equitable access to policies, and in this case, healthcare. And so social determinants of health and sex and gender-based analysis and health equity impact assessments look at people from kind of a singular model, a singular mode. And intersectionality says that you have to look at people in an intersectional way. So it's not sex, period, gender, period, race, period, culture, period. It's all encompassing and all together. And as well, intersectionality, again, attends to themes of power. It tends to themes of power in our social structures, in our social systems that make up an individual, that these other approaches do not so much. And so we'll keep on going about that. Next slide, please. So I took all of that and I applied it to the Ontario Dementia Strategy, because my father with dementia, when he was going through things and this dementia strategy came out, I thought, okay, great, let's see what it's going to say and do for people. And let's see what how it's going to attend to the needs of immigrant seniors from different ethnocultural backgrounds. And so the Ontario Dementia Strategy was part of a 2015 Patient First initiative. It was a way to strengthen home and community care in Ontario. It was a patient-centered approach to healthcare that wanted to improve the patient experience and the provider experience and patient outcomes by putting patient needs at the center of healthcare delivery and healthcare research. So from that, dementia care was part and parcel of that. And so 2016, it was announced that this strategy was going to be developed and implemented through a series of consultations. 2017, April, it was announced that $100 million was going to be given towards the strategy and its implementation over 3 years. So 2018, 19, and would have concluded in 2020 of this year, actually this past summer. And so the $100 million investment was to really help expand access towards dementia care, specific programs, behavioral support models for home care services and for long-term care services. It was also going to be used to help increase access to integrated and coordinated support. So the LINS, which is now Ontario Health Teams, CCAC, you know, occupational therapists, physiotherapists, and what have you, to really integrate all these systems of care for people. And it was also supposed to provide enhanced dementia training for primary care providers. Remember, I talked about primary care physicians, you know, sort of being the gateway to dementia care for people, and sort of equipping them with the means, the knowledge, the evidence-based practices to be able to support people. So that was sort of the rationale for the investment for the $100 million over the 3 years. Next slide, please. So in that, though, just as a little caveat, since 2017, we've had a change in government, and we've had the COVID-19 pandemic, which, you know, since then, we haven't really seen a lot come out of what's been happening with the dementia care strategy in terms of evaluations. What's been public facing hasn't really been a lot. And so hoping that in the next year or so, we're going to see reports of sort of what the evaluations have said and how effective this strategy has been. Research has shown that people do prefer, for the most part, prefer to be at home if experiencing dementia, as opposed to being in long-term care homes. So that might have been part of the rationale for sort of orienting the strategy towards home care and community care versus institutionalized care. But again, you know, thinking about who they surveyed for that research, you know, always makes me thinking about the experiences of immigrant seniors. So the public consultations. So the strategy was actually based off of public consultations. The Ministry of Health went out into the public, and they went to different locations of Ontario, and they asked people what they needed, what they were experiencing and what they needed, and what would make their dementia journey better for them. From these consultations, 6 themes, I'm going to call them buckets. It's going to be easier probably to differentiate when I speak about my themes. So 6 buckets emerged that people said, this is what we need. This is what we feel our loved one needs to experience the dementia journey in an equitable way, in a better way, to get us to a better health outcome. These 6 buckets were supports for people living with dementia, accessing dementia services, coordinated care, support for care partners, a well-trained dementia workforce, and stigma awareness and brain health. So this is sort of what came out from the consultations. Can I have the next slide, please? Thank you. And so when I was reading when I was reading the dementia strategy, I was trying to think of a way, how am I going to analyze this? How am I going to really do a deep dive into this and really think about ways that this is being equitable? So I looked at the intersectionality-based policy analysis. This is a framework developed by Alina Hankinski from Simon Fraser University. She's a scholar on intersectionality, gendered health, women's health, and health of marginalized groups. So she developed this framework to help understand the various equity-related impacts of policy. Oftentimes, when policy is developed, it's to sort of, you know, get everyone to be able to attend to the needs of everyone as best they can. And sometimes what ends up happening, you get this fits right for everyone model. So, you know, best fit for everyone's model in policy, which obviously leaves some people falling through gaps. And so this framework helps to promote equity-based improvements in social justices for increasingly diverse populations. So it helps to enhance decision makers of policy, decision capacity for stakeholders and policymakers, and it hopes to offer new methods to understand the equity implications of their policies. So with that in mind, next slide, please. So, and my mind works in shapes and structures, which is why you see a lot of this here. So I'm going to describe this in shapes and structures. So the intersectionality-based policy analysis framework, or IBPA framework, it's sort of founded on 8 guiding principles. And if you remember, I talked about the central features of intersectionality as a theory. So there's 8 guiding principles for this theory, or for this framework rather. And you can think of it kind of as soil. Think of it kind of like a soil that you plant things in. So there's 8 guiding principles, and it's the soil. And from that soil, or from those 8 principles, you have 12 questions or 12 flowers that develop, that come up about this. And these 12 questions are kind of the guide by which you're going to analyze a policy. Next slide, please. Thank you. So the 12 flowers or questions that have come from these 8 foundational guideline or pieces, these 12 questions are separated into descriptive and transformative. The descriptive questions, they sort of recontextualize the policy problem, and they look for hidden gaps and hidden assumptions, because often in a policy, it seems to be great, the one size fits all model. We're trying to be equal. We're trying to get at as much of the population as we can. But even within that, there's hidden assumptions and hidden barriers that may not be apparent to people that are going to adversely or negatively affect some groups over others. So this IBPA framework helps to really tease out those little hidden assumptions and bring them to light so we can deal with them better. The transformative questions or transformative flowers, they focus on responses and solutions aimed at social and structural change. So again, intersectionality looks at social justice and features and structures of power, systems of power, and how they have created barriers and created exclusions. And these transformative questions helps to identify those as well in policies. So it's kind of a two-pronged approach to making sure that policies are equitable and policies capture I don't want to say marginalized groups and populations. Next slide, please. So for the descriptive flowers, descriptive questions, if you can see here, there's 1, 2, 3, 4, 5. Number 4 was what I focused on. How are groups differentiatedly affected by the representation of the problem? So basically, the problem here is dementia care. And the problem here is access to dementia care, dementia that's going to be able to reach larger swaths of the population. So this question is asking, well, how are different groups in society, how are they affected by the way we represent dementia? The way we talk about dementia, the way we conceptualize it, what groups are included, what groups are left behind, how and why, what are the impacts of that? Next slide, please. This transformative piece, or transformative flowers, this talks about sort of what potential approaches can be used to promote discussion of the problem across different affected groups. So that was question 6, the first actual question. What inequities actually exist in relation to the problem? So when we think about dementia, what kinds of barriers, what kinds of differences are actually existing for people and actually existing for groups of people? So these were my 2 guiding questions looking at the Ontario Dementia Strategy. And so next slide, please. Thank you. So here's a bucket of the 6 buckets. Here's I represent a slide of the 6 buckets. I'm going to quickly click over to the next slide, just keeping in the interest of time. Next slide, please. Thank you. So there are 3 main themes that I found when I went through these consultation questions. There are 6 buckets. Underneath each bucket, there's a series of questions, right? So the 6 buckets represent broader themes, and then within each bucket are questions that were asked of the public in terms of their dementia experience and what they would like to see. And so when I went through each of the buckets, each of the 6 buckets, and I went through each of the questions in the 6 buckets, I noticed some dominant themes that were reoccurring. One of those themes here is dominant Western medical frameworks and ideologies. So one of the consultation questions was, what supports or services do you think are essential to enable a person living with dementia to remain at home and be active in the community? So basically, a person with dementia, what do they need to be able to stay at home, feel competent, feel confident, feel safe, and to be active in their community? The other question is, what characteristics of high quality programs would help people with dementia and their care partners? Right off the bat, these questions, for me, were exclusionary. Right off the bat, these questions are framing dementia in such a way that are housed in Western terminology, Western conceptions of mental health, Western conceptions of dementia. This is going to exclude people who have different cultural interpretations, different cultural understandings, and different language of dementia and symptoms of dementia. So right off the bat, if I was going to go to this consultation, seminar, workshop, or series, and I had different understandings of dementia, I would not be able to answer these questions in a way that whatever resulting policies would come about would have my experience represented. So that was theme number 1, the sort of dominant framework of understanding dementia and dementia care. Next slide, please. The slide after that. Thank you. Engagement with the healthcare system. So again, some questions that were asked in the consultation process were, what skills, abilities, standards, and best practice guidelines do healthcare professionals need in order to provide excellent dementia care? I chuckle at this question because there's a lot of assumptions in this question. a lot of assumptions that, you know, these immigrant racialized seniors, ethnic culturally diverse seniors have gone to healthcare professionals and healthcare providers and engage with healthcare providers about their dementia symptoms, maybe getting a diagnosis and beginning treatment. Research has shown that immigrant seniors from different racial, ethnic, cultural backgrounds have barriers to accessing dementia care services, and they have barriers even getting to the gateway, their family care providers, for accessing dementia care services. So again, this question seeks to exclude people who have different experiences on the dementia care journey. And in this case, these people are those coming from different cultural, ethno-cultural backgrounds. Even the language within this question, best practice guidelines. And I chuckle at that because not a lot of people knows what best practice guidelines are. I barely know what best practice guidelines are, and I've been in healthcare for many years. And so asking people who may not have the language or experience or exposure, this kinds of questions, is going to exclude them from whatever the outcome of these questions and consultations are going to be. The other question they asked, have you ever experienced or observed seamless, well-coordinated dementia care? Again, the assumption is that people have, you know, encountered this or been exposed to this or even know what seamless, well-coordinated dementia care is. And coordinated dementia care with whom? Their primary care provider, community support groups, immigration services, like what does that mean? So all of these questions I found to be very exclusionary and very sort of constructing a dementia patient that is not attending to the realities of immigrant seniors. The third theme that I found was social determinants of health for racialized immigrant seniors. So for example, what services or supports, for example, home care or adult day programs are effective to assisting care partners of people with dementia. Now, research has shown immigrant seniors from different racial, ethnocultural backgrounds, they're not in the highest income bracket. Home care and adult daycare programs are expensive, even with subsidies. Transportation to get to these day programs, you know, hiring PSWs depending on the needs that you would have at home. And as well, for some cultural groups, again, like I said, they don't necessarily subscribe to home care-based models because, you know, mandated that the family steps in and takes care of the loved ones. So these kinds of questions as well are making the assumption that people who are answering this question come from the same socioeconomic background, the same understandings of dementia care services and supports, and that again leaves out and excludes people who aren't experiencing it in the same way. And so when we think about the two questions, the descriptive flower questions I was talking about, when we apply those two questions to the buckets and the themes that emerged, we're seeing that who is privileged and who is not privileged by this strategy. The people who are privileged are those who already subscribe to Western frameworks and understanding of dementia care, for those who already have a good relationship with the healthcare system, and for those who have the means, and for those who have the cultural alignment with Western culture to be able to access dementia care services. And those who are not privileged to have that, their voices and experiences are not going to be reflected in whatever resulting policy that comes about or whatever resulting interventions that come about from this strategy. And that was really important to note, because for people who are experiencing dementia on the dementia journey, the amount of support that they receive and the amount of options and access they have, services that they have access to, is really helpful in maintaining their health and providing a better health outcomes and health status for them along the journey, and for their loved ones and for their family members and communities. And so the conclusion from this work that I looked at was that the dementia the Ontario Dementia Strategy, while it had earnest intentions, I want to say, it relies on a lot of assumptions of a universal understanding and experience with the medical system and the healthcare system and dementia care. And in that of itself, it leaves off a swath of people. And so here's where we talk about how systems create people based on intersectionality. So the Ontario Dementia Strategy and the healthcare system, through these questions, has thus constructed a dementia patient, the ideal dementia patient. The ideal dementia patient is someone who speaks English, someone who understands the Canadian healthcare system, someone who understands what dementia is, someone who has the means to be able to afford or partake in dementia care services. And so the healthcare system, through looking at intersectionality, different locations, different identities that people have, has created a dementia patient, the ideal dementia patient. If you don't have one of those identities, speaking English, same cultural paradigms as Western culture, a high socioeconomic status, if you don't have those locations, those identities within your person, you are excluded from the dementia care strategy and from the aims of the dementia care strategy. So that's what I was talking about when I was saying that these systems create our identities, and in the creation of these identities, they interact with these systems. And in this case, it's the healthcare system. And so what actually needs to happen, one of my recommendations, is that there needs to be a local and individual cultural accommodations for racialized ethnocultural immigrant seniors. These policies and the consultation process needs to be opened up. It needs to be more inclusive. When we think about consultations, you know, when do they have the consultations? Are they in the day when people can't get to them? You know, are they through technological means that people may not have access to or be familiar with? And so when we think about the way that these policies are designed and we think about who they're trying to address, we need to have a broader lens that really is focused and housed in equity and themes of social justice to make sure that everybody really is truly included, pardon me. And so this is the bibliography, and I wanted to put up, can I get you to put the last couple of slides up? Keep going, sorry. Keep going. Keep going. Keep going. Keep going. So there's a book, Women's Health in Canada, Challenges of Intersectionality, edited by Marina Morrow and Alina Han-Kaminsky and Colleen Varco. So what I just presented is actually a chapter in this book that is forthcoming. It's just gone for a second peer review, so it should be published, we're hoping 2021, all things hopeful. So for those who are interested in more of this topic or other themes of intersectionality and women's health, please feel free to check out this book when it becomes available. And that is my presentation, and I will take questions and comments for the next little bit.
Thank you, Ngozi. So first, just a comment. Thank you for the definition of intersectionality related to race, gender, and class. And then a question from Violaine, which I'm trying to, so she was thinking, is intersectionality looking at people in a holistic way or in a global way?
Yes. Yes,
Okay.
Intersectionality is looking at people not reduced to the sum of their parts, but looking at them in totality of their parts. So, you know, when you think about judicial systems, and I'm going to bring up a topic that has been in the news a lot this past year. When we think about judicial systems, who encounters a judicial system and how are they treated within the judicial system? We think about the intersections of people's identities and how the coalescence of those identities are, how they form a relationship with, you know, the police, with, you know, the legal system, with the rehabilitation system thereafter. So intersectionality really does attend to all of the identities of a person and not just one.
Okay. And another question is from Anil Sukija. I feel that as of date, the government policy is based on equality, but the need is the emphasis should be on equity. Long-term care homes are not sensitive to the cultural needs of various ethnicities like language, food habits. A policy shift is needed. What are your thoughts on this?
I absolutely agree with you 118%. When I was doing the research for this, I spoke to some folks who are managers and directors of programs for seniors. And I asked people, do you have a policy, an actual program policy or some sort of guideline that's going to incorporate the needs of your diverse population? And they all said no. What they do have, though, they have this sort of ad hoc kind of informal way of attending to their needs. So if someone brings in, they might have cultural food day where people bring in a dish from their cultural background. You know, they might have the family translate if they can. So it's sort of piecemeal together in the way to support this client base, but there's nothing institutionalized. So what you have, you keep having these reproduction of gaps, and you keep having this reproduction of points of exclusion for these groups where their needs aren't being met. And that's going to have an impact on the service that they receive and how they feel about that service. It's often said that people with dementia may not remember, but they remember how you make them feel. And so if the attention to their cultural specificities and their cultural identity isn't really taken into account, that's felt. And that's experienced by them and their family members. So absolutely, there needs to be policy, there needs to be direction that can incorporate the diverse experiences of this group, because in reality, we can't have a one-size-fits-all model and then just, oh, let's add on, you know, cultural food day. Everybody bring in your, like that's not really going to cut it. It needs to be more dignified, and it needs to be more authentic, I feel.
Totally agree. Another comment, my fear of this topic is food for fuel for the anti-immigration people. That's a comment, and after this,
I just want to address that comment. You know, by virtue of me being in this country and sitting here talking to you is fuel for anti-immigration people. I don't think that there's anything that, you know, anti-immigration people are going to find that's going to appease their fears and allay their fears. And frankly, that's not my concern. I'm not here for the anti-immigration people. I'm here for people who need support and services for racially, ethnically, cultural, diverse immigrant seniors. And so, you know, in behavioral change, there's three camps of people: people who are pro what you're doing, people who are on the fence about what you're doing, and people who are just absolutely against what you're doing. Just, they don't want to hear it. Anti-immigration people are in that camp. They don't want to hear it. They want Canada to be, you know, made in their image, and that's what they want. The reality is it's not. And so people who are sort of in the middle and people who are pro, that's where I direct my research towards. That's where I direct sort of my energy towards. Anti-immigration people, okay, I'm not here for you though.
Excellent point, excellent answer. So, Ngozi, we're now going to open it up for people to ask questions directly,
Sure.
because some of our seniors were having a difficult time typing questions. So we're going to allow people to talk, and Marlene is going to take over from that. So do we have somebody who would want to ask a question? I think it was Elaine. There's 4 participants raised their hands. Anna Maria had a comment, so if we can go to Anna Maria Cruz Valderrama. If you can unmute her.
Okay, thank you very much, Sybil. Thank you for the presentation. Excellent.
Hi, Maria.
Hi, how are you?
Good, how are you?
It's fine. Excellent presentation.
Thank you.
I want to go back to your recommendation. I want to get back to your recommendation, and you have one that is said, increase cultural awareness. In that, I'm over 150% with you. But I think that creating awareness is in our hands. I am a social activist, and I see that us immigrants are excellent, top-notch in promoting our contributions to this country, language, poetry, business, you name it.
Yeah.
Okay. And for me, the human life, it has positive and it's like a balance. Okay. But we fall short, extremely short in voicing our needs. We don't want, it's like a kind of feeling shame. There is no shame in talking about our needs. And that's what we fail, and that the system reflects that's our own failure. So is more the creating cultural awareness is the role of each of us in this society. In the same way that we contribute in the positive, we have to talk about our needs and not to feel any shame and not expecting, because so far I have the feeling that we expect for them to resolve our problems, like a glass, like, you know, the glass that they're reading our minds. No, because in the different forums that I take part, where I see the predominant groups, I mean, or mainstream groups, they are there, but we are not there. 99% I am alone. They are voicing down. And why is that? It's because we ourselves, again, are weak at that point. And we have the right, we have duties and rights. and it's our moral duty to speak about our own needs. So that's what I think about how creating, increasing cultural awareness. We have to voice that out.
And
Thank
you're
you, Ana Maria.
Thank you,
Thank
Ana
you.
Maria. You're absolutely right. I do feel that, you know, the needs of communities have to come from within them. And how do we make that happen? How do we empower communities and equip communities to have the confidence and the means to go out and do research? Because research done by the community, within the community, to me is the best kind of research, because we know what we need and we know what's going to help us succeed. So how do we do that? So I'll say at the top, there are a lot of, and you know, I'm going to say this, but fine. There are a lot of government-funded initiatives and strategies and programs at the provincial and federal level, especially during COVID. There's a lot of grant money coming out for people to try to research how COVID is impacting various communities in Ontario and in Canada. And that's a way to tap into that source of funding to be able to do research within your communities and be able to take the results of that research and turn it into actionable items, right? So you can do some research and go to your local health community center and say, hey, we've done this research. This is what we've found and developed. Let's partner together to have, you know, community awareness, cultural awareness pieces for our community members on how best to support themselves and practice these things. And you're right, it has to be something that we have to help ourselves in solving, and taking that to other institutions and other systems and partnering with them so that we can actually, you know, lead some of the cultural awareness pieces. I agree with you 100%.
Okay. So Ngozi, we have a few more raised hands and questions. Sure. And sure. The next one is from Eileen Massard.
Sure.
She's muted, so if she can unmute herself to ask a question. Okay, so then we'll go to...
Oh, no, she wasn't muted. Oh, no, now she's muted again.
Okay.
Oh,
there you go. Okay, great.
I think I just raised my hand by mistake. I'm listening, but I didn't have any questions. Sorry.
Okay, so we'll go to the next one then. It's Imani Navar. You can unmute yourself. Okay, this is the first time we are trying this out, so there's little issues we are encountering. Ben Burgon had a question. Maybe he's... Yes, Ben, unmute yourself, please. Okay, we'll go to Esperance.
Hello.
Hi there.
Can you hear me?
I can hear you. Yes, we can hear you.
I appreciate your presentation very much.
Thank you.
I'm relating to you because my husband is going into that kind of situation.
Mm-hmm.
Now, his way of life was very different from, or he's Canadian and he's English Canadian. His way of life is different from ordinary Canadians because he was in the foreign service for so many years, even before I met him.
Mm-hmm.
Now, we have difficulty trying to convince him about a lot of things.
Mm-hmm.
And he doesn't want to see me because he doesn't want me to see him in this situation.
Mm-hmm.
Now, how do I go about helping my two daughters in taking care of him with regards to his dementia growing every day, you know?
Where are you? Can I ask what region or city you're located in?
He is in the East End. He is in a nursing home right now, and I am living in the Hintonburg area.
Okay, and you're asking to best support your daughters and yourself?
Yes.
So that's a great.
And also I am from a different ethnicity. I am from the Philippines.
Okay.
You know, and I only lived with him in several countries, you know, so his other experiences in other countries, I really don't have much idea what it is.
So first off the bat, I'm not a clinician or a social worker in that regard, so I want to be very careful in how I can support you on that, because your question is very important and very common for people. I can only speak from my experience, and that might be helpful to you or not, but for myself, I referred my family to the Alzheimer's Society, the local Alzheimer's Society. We're in Peel, in Mississauga there. And I refer them to them because the Alzheimer's Society is really adept at helping caregivers and loved ones come to terms and understand what the changes that someone is experiencing on the dementia journey. Because everyone takes a dementia journey. Once it's been diagnosed in the family or in the social circle, everybody takes an aspect of that journey. And the most important feature is to support the caregiver to get support and the loved ones to have support, because dementia is a very unique journey, and it can bring up a lot of challenges for the supportive people to the person. And so we connected with the Alzheimer's Society, and that got them in contact with support groups coming together and talking to people, which might be difficult in the COVID era. Certainly got us in contact with a social worker who was able to provide us with my family what to expect, what to look for, what to be prepared for, and as well prepared for at home, because the change at home, the change in the family dynamic, not just the physical change, but the emotional, mental change in the family dynamic was also something to be attended to. Now, my background is African background, so there is no services regarding African immigrants experiencing dementia, I know that. So we had to sort of formulate how to best support my father from a cultural perspective in terms of language, food, speaking, understanding certain things. I used to get phone calls from the Alzheimer's Society, the day program, and they would say, your father's doing this, we don't understand. And I would say, in his mind, he's back in Nigeria, circa 1950. So that's why he's doing that. So we were able to support the staff in, supporting my father. But in terms of getting your daughters and yourself support, I would suggest first Link. It's a program within the Alzheimer's Society. It puts you in contact with counselors and service providers that can help you along on this stretch of your journey. So, you have some support, some understanding. I don't know of Filipino community organizations in Toronto offhand that are supportive with dementia. If you give me some time, I might be able to put you in contact with someone. I am thinking of a couple of organizations. I'm thinking of one. But if you get in contact with me afterwards, I might be able to put you in touch with someone.
I find it very hard because I have had experience of looking after other people with dementia. But now when it's personal, I find it very difficult.
Of course, if there's a personal connection.
I can't seem to be objective.
Of course, because it's hitting home now. It's your own person, it's your world, it's your home. And there's a lot of changes and differences that you're going to observe, that you are observing and going to continue to observe, not just within your husband, but also within yourself. And again, that's why I really impress upon connecting with the Alzheimer's Society to getting, support groups, social workers, counseling services, because when I tell you it really helps, it really helps you to situate what you're experiencing and what you're going through.
Thank you very much.
You're welcome.
In Ngozi, we have a question from Dr. Prabir.
Sure.
Can you hear me?
I can.
Okay. First, may I call you Ngozi?
Please do, yes.
Because I had friends from Nigeria when I was studying at Imperial College. That's
wonderful.
The question.
Wonderful.
Very good ones. First, I want to congratulate the speaker for the excellence of her presentation. I, for one, would like to go through the PowerPoint presentation in much more detail, think about it, and then have some more detailed and profound questions, I hope.
Sure, okay.
But I'll give you a comment and two questions. The comment in this, by the way, you're talking to a ex-federal public service employee. The comment is this: our health services and educational services in Canada, I think, were founded on the concept of universality, or at least universality for a basic set of services. And in those days, the concept of universality could only be achieved through the concept of equality. In other words, you did not have the ability to treat every student differently or every patient differently. That's an industrial society mindset. And it seems to me that in trying to balance intersectionality with universality, you're trying to move from a mindset and a set of policies which treats everybody as the same or essentially the same. For instance, your ideal construct of a dementia patient, to treating every person individually.
Mm-hmm.
You know, if you think of the intersectional construction, then in effect, every person is unique.
Mm-hmm.
Now, this is not a theoretical issue because it involves the allocation of resources.
Mm-hmm.
And if we all agree that the most efficient way of treating dementia is to allow people to remain in their homes
Mm-hmm.
rather than be warehoused in long-term care homes or retirement planning homes,
Mm-hmm.
then how do you make this argument to the people who are responsible for allocating the resources, in this case, the provincial governments? That's the overall question. Now, within that, there are detailed questions about what each individual community can do to its. I come from an Indian background. We've tried to find out some things about our community. Sybil can tell you more about that. But the general question remains, how do you make that argument to the people who have control over the allocation of the resources?
Well, the counter argument, and I'm going to answer your question, but I'm going to offer a counter argument. What is the alternative when we don't do that? So right now we're seeing the results of this universality approach to healthcare and dementia care, and we've seen the impact of that. And we're going to continue to see the impact of that, given, you know, the sort of background that I laid with aging populations and increased immigration. The one-size-fits-all model does not work. It does not work in any field of health. It doesn't work in you know, cardiovascular health. It doesn't work in cancer treatments. It doesn't work because people are experiencing health differently, and different communities are experiencing health differently. And so you're right. There is a tightrope that intersectionality walks, because you know, is it realistic and plausible to attend to every single difference or every single constitution of differences within every population? No, that's not realistic, and we're not there yet. But there are some ways, as the intersectionality-based policy analysis framework has demonstrated, there are some ways to look at broader impacts of equity when it comes to policy. We can't look at policy anymore as a one-size-fits-all model. It doesn't work that way. For those who fall out of that one-size-fits-all model, where do they go? For example, Canadian healthcare was designed, or you know, the healthcare system as we know it really was designed after World War II. And it was designed as a sort of reactive mechanism to events of the war. And it was designed to be, to handle acute medical issues. It was never designed for chronic medical issues. It was certainly not designed to be proactive. We're trying to be more proactive with health promotion. Canada is a leader in some ways on the world stage for that. But we're not, the healthcare system in itself is not designed to be proactive, and it's not designed for chronic illnesses and issues, and it's not designed for the influx of people who need these services at the beginning. Then when we add on, you know, cultural pieces, gendered pieces, sexual orientation pieces, it's, you know, there's a lot to be desired. But we keep on going, and we keep on modifying, and we keep on implementing new methodologies for it, which intersectionality is. It's not going to hit every single person, but it's going to include those who have been excluded and bring them into the fold, and hopefully develop policies that become broader to include everybody underneath. Instead of the policies are much more narrow now, and then we're adding, oh, okay, let's add on people who are sexually different orientation. Oh, let's add on the immigrants. Oh, let's add on the refugees, because the adding on feature has left people, it has left people in gaps. So we're trying to open up the policies to include everybody in at the outset. And the resources for that, there are resources for that. We have the resources for that. Where we choose to allocate provincial finance and the federal resources is a different question, but the resources for that are there. That's how I answer that question.
Thank you. Our next
Thanks for
question.
the answer. By the way, I in no way implied that I believe in the one size fits all.
Oh, no, I know
I
you
agree
don't.
with you
I know.
completely
I don't.
that our Western medical system is designed for interventions to treat acute issues. It does not work very well with chronic mental issues,
No,
and
not at all.
particularly with chronic mental issues
Not at all. Yeah.
like dementia, Alzheimer's, and so on.
Yeah, we're just now getting attuned to dealing with, things like depression and anxiety. We have a long, like we're better than we were before, but we have still some ways to go for sure.
Thank you, Dr. Purby. We'll start with Dr. Chandra for the next question.
Hi, can you hear me?
Yes,
Yes.
I can.
I have two prongs to my question.
Okay.
One prong is COVID has revealed or unearthed different problems, especially in the senior care who are living in homes. I think all of us are responsible to get to the government, either the provincial or federal level, to organize funding or better way of management of these homes, which is very, very important. And the dementia part of those homes, people are segregated and they are in different levels, needs to be readdressed and taken care of. I've heard from people, from friends, how pathetic the living conditions exist in those areas. And this is very, very important. We are all people and we need dignity and care. Which end of the life we are, we need to be taken care of. The second prong of question is, I agree with Dr. Purby. If we go to more individual care, not nationalized care, we are kind of segregating, or the funding kind of gets smaller and smaller and smaller. So if we united together and get funding for the united reason, yes, it will cover everybody. But if we keep saying, of course, the care, I agree with you 100%. The care is very segregated. People with, say, money are able to get a better care than people without money. And this is where we have to work, that the commonality of care is equal to everybody. And if we work on that, maybe it's not going to happen in my lifetime. I'm already a senior citizen. It will happen in future. And that's where I would like to focus the attention better. I hope you agree.
I do. I did a policy analysis of HIV interventions, the HIV funding and guidelines in Ontario a little while back. And I looked at the way funding and supports were distributed throughout various cities, and within those cities, throughout various communities. And some communities, it's no secret, some communities are better off than other communities. Some communities have started, from inception, have started off in better positions than other communities. So when this funding was given out to one community A versus community B that had already been struggling wasn't able to necessarily make use of the funding as much as community A. And that's when you have this sort of equality, this equal representation of distribution of services and funding. And these two communities were separate and segregated in that they wanted to have HIV services that were really particular to their client base. And you're right, from that we saw community B's services were not as robust. They weren't as far reaching as community A. So people in community B were still suffering. And so when we think about it from taking a step back and thinking about policy, is there a way for provincial governments and federal governments to be able to sort of drive that lead in terms of making sure all the communities are represented in an equitable way in terms of distribution of funds and interventions and services and resources? That is a big policy question, and that is something that I don't know that the policymakers are looking to attend to right now. I think sort of the consensus is that the community best knows what the community needs, and the government will give them funding and support to do that. but the government is sort of, I want to say, reticent for taking the lead and saying, we're going to come in and do this with you. Doing it for you is something different, but doing it with you as opposed to doing it for you. And so it's very important that we have more inclusivity in our policies and sort of look at ways that there could be silent or subtle methods of segregation, like you said. And that is very important because that segregation will then just reproduce and lend itself to more inequalities down the road. So that is a very good point. I do agree with you.
I have one more little thing. You kind of identified all these problems. And coming from the little bit of research background, I feel you produce a paper and you produce the results and conclusion. And for somebody to adapt that conclusion takes 10, 15 years. I find there is why this division, why people are finding it, any research background and policies that are come as a conclusion to come into virtual reality of adapting them is not applicable. There's no policies are there.
Well, yeah, and you know, policy making is a slow process. It's not a quick process. There's a lot of institutional established practices and institutional established culture that can be slow to change. Policy is not, you know, we decide something in January and by April we have a new, you know, we have a new policy. In extraordinary circumstances like COVID, yes, you'll see the policy process get a little bit quicker, but overall, arcingly, generally, it's not. And so to the caller, Anna Maria, who was talking about, I believe it was Anna Maria, maybe not, who was talking about activism within our communities, that's where we come in. That's when we have to strike up and say, hey, you know what, we're experiencing this. We need some support. We need some attention on this issue, on this problem, because here's how it's affecting us. Sometimes we can't wait for the top down to come down and say, hey, we're going to support. Sometimes we've got to go from the bottom up and say, hey, we need that support, and to kind of meet in the middle. But on a whole, though, policy is not the most speedy process, and that's one of the criticisms of policy, and you know, a lot of people hold that sentiment.
Thank you very much for taking my questions.
You're very welcome.
So we'll take one last question from Fatima, and then we'll do some closing remarks. So Fatima, if you're ready.
Yes. Can you hear me?
Yes, I can.
Okay. I am a retired federal civil servant, and I work on policy. And as you said, policy takes a long time. Our system of government is based on the 2 years of firefighting. COVID comes around, everything comes to a halt. We do whatever needed to be done. Then this goes away, something else, and then 2 years. The second 2 years is promises for something, and everything that has a long term, like health, education, environment, are all something in the future. We can deal with them. We can let people research like you and me. I did policy advice and I did policy research. We can go on research and come back with recommendations, with policy recommendations, okay, but we're now fighting something. So the problem is a little bit more than resources as well, resource cost of how much it would cost you to make a policy. So I agree with the fact that the communities need to do their work, and also you need to look at the NGOs, the civic society, because the civic society has a role to play.
Absolutely.
All of these, like we have the immigration NGOs that deal with women issues and stuff like that. Put that on their agenda and what they can do we've got, for example, I am Arab, I'm Egyptian Arab, so there's a lot of Arab community. What can we do for you in the hospitals and in dementia care that can help, and not expect the government to solve everybody's problem?
Absolutely.
Intersectionality is cross-cutting, so they will look at you and say, okay, thank you. And they can't do anything about it. It's generality. So I'm with this idea, and I'm fighting my own
Egyptian community to say, okay, let's look at what's happening to us as we grow old. I look at the Chinese community. They have 2 floors in different long-term facilities that are dedicated to Chinese. They're more organized. So they have solved a bit of their problem, not all of it, but a bit of their problem in having a floor for them. So can we do that at the space? We're dealing with shortage in general, universal shortage. So this is my comment is, thank you very much. You're really raising very good questions. And I dealt with these problems with my parents. Both of them had dementia, and both of them passed away, thank God, before COVID. So anyways, this is my take on policies.
Yeah, no, I agree with you. I think, you know, as I've been doing these presentations and preparing for them and doing some thinking, you know, there really needs, in my opinion, there really needs to be a big emphasis within cultural communities about the realities of aging. A lot of cultural communities think, oh, everybody's going to age like we did back home. You know, it's going to be fine. If there's any issues, we'll get someone's cousin's, auntie's, neighbor to come in and sit with our loved one and everything will be well. You know, but the reality is it's very different to age in Canada for a lot of these immigrant seniors, and even first generation, second generation, it's very different. And I feel that there's a kind of, I want to say a wanted denial of that difference, and that, you know, the children's children experience that. And so what is a way that we can get our communities more engaged, feel less scared, you know, feel really attuned to the realities of aging in Canada so that we can support them proactively and not reactively. And for my own personal research, for my PhD, that's what I'm going to be looking at, seeking ways to increase awareness and competency around health issues related to age in immigrant communities, because we don't have a lot of those conversations. We don't have a lot of that knowledge disseminated around, like, you know, at large. And so people do, like yourself, are experiencing that in communities saying, oh, it's not in our community, it's fine, we're okay. But then when things happen, people are sort of, you know, left without real supports in managing things. So that's a very excellent point, and I agree with you very much so on that point.
Thank you, everybody, for your questions.
Thank
It was
you.
very thought-provoking. I'd like to thank everyone for taking the time to join us today. It's such an important topic, and we hope Ngozi has inspired you to become advocates for change. Thank you, Ngozi, as always, for inspiring us. We have so much to do and so much to learn, but by building with our strengths and creating new pathways for change, hopefully we will have culturally appropriate dementia care service and equity and equality for all our seniors, as well as others who are going through the struggle of finding care, proper care, as well as we talk about caregivers. Also want to again thank our funders, Center for Brain Health, Aging, and Ontario Trillium Foundation, New Horizon for Seniors Programming. Our next webinar is going to be on September 29th, Building Strength, Inspiring Hope, Shifting Cultural Competency in Practice by Dr. Linda Cogney-Demens. So I hope you all can join us for the next one, same time, same day, next Tuesday. Thank you again. And if you need any questions to be answered, please connect with me. You have my email. We'll hope to create some more partnerships and working together to find some way we can change policy. So thank you again, Ngozi.
Thank you, everyone. Thank you for your contributions. Thank you.
Take care, everybody. Bye-bye.
Bye-bye.